Today we're going to talk about external fixators, what they are, when they're used, and how nurses manage patients with them. These devices may look intimidating, but with the right knowledge, they can be managed safely and effectively. What is an external fixator? An external fixator is a device used to manage fractures with extensive soft tissue damage, complicated fractures of the long bones or pelvis, or conditions such as non-union and limb lengthening. Pins are surgically inserted through the skin and bone and then attached to an external frame. The frame keeps the fracture in alignment while allowing wound care, early mobility, and joint exercises. External fixators are especially useful for severe comminuted fractures or injuries where internal fixation would cause too much blood loss. Advantages and disadvantages. Advantages: immediate stabilization, less blood loss compared to surgery with internal fixation, allows for wound care and soft tissue treatment, promotes early mobilization and weight bearing, adjacent joints remain active. Disadvantages: risk of pin site loosening, increased risk of infection, which can progress to osteomyelitis or septic arthritis, psychological impact of the bulky frame, nursing role in management. Patients may feel anxious about body image when they first see the device. Nurses prepare them psychologically by explaining what to expect, reassuring them about mobility, and creating a safe space for concerns. After application, elevate the extremity to the level of the heart to control swelling. Cover sharp points on the frame to prevent injury. Monitor for complications such as pressure on skin, nerves, or vessels, and watch closely for acute compartment syndrome. Perform neurovascular checks every 2 to 4 hours. Inspect pin sites every 8 to 12 hours for redness, swelling, warmth, pain, or drainage. Mild redness and serous drainage are normal in the first 48-72 hours, but ongoing signs may indicate infection. Pin site care. There is no single best method supported by evidence, but principles include aseptic technique, cleansing each pin separately, and dressing as prescribed. Chlorhexidine may be used weekly, but nurses must monitor for allergic reactions. Quality and safety nursing alert. Nurses should never adjust clamps on the external fixator. That is the provider's responsibility. Report loose pins or clamps immediately. Exercise and mobility. Restricted activity increases the risk of complications like thrombus formation. Nurses encourage isometric exercises as tolerated. As swelling decreases, patients begin mobilizing within prescribed weight-bearing limits. Following weight-bearing orders is essential to avoid loosening pins. External fixators are usually removed once soft tissues heal and infection risk has passed. Sometimes the fracture is then stabilized with a cast or brace for continued healing. Specialized fixator. The Ilizarov device. The Ilizarov fixator uses multiple wires attached to a circular frame. It is used to correct angulation, treat non-union, and lengthen limbs. The device works by gradually pulling apart the bone cortex with daily rod adjustments, stimulating new bone growth. Because these devices may stay on for months, patient and caregiver education is critical. Perform daily pin site care using clean technique at home. Monitor for signs of infection, irritation, or loosening. Check frame integrity daily. Report changes in sensation, movement, or circulation immediately. Work with physical therapy for gait training, transfers, and safe ambulation. Conclusion: external fixators provide stability and promote healing in complex fractures, but they require diligent nursing care. Neurovascular monitoring, pin site care, patient education, and psychological support are all vital parts of nursing management. With proper care, patients can regain mobility and return to function even after severe injuries.